Hello, my name's Arjun Ghosh. I'm a consultant cardiologist at Bart's Heart Centre and University College London Hospital. It gives me great pleasure to be with you today virtually for the launch of the Pelvic Radiation Disease Association Toolkit. Unfortunately, I have had to record this talk and am not able to join you live, but I hope you find this useful. So what are the cardiovascular side effects of radiotherapy? This is a very nice reference article that I will be mentioning a few times, and this is the International Cardio-Oncology Society guideline on radiotherapy and its cardiac side effects. So as we can see here, they do talk about abdominal and pelvic radiation, and they mention that aortoiliac atherosclerosis, renovascular hypertension can occur. They talk about the ways to assess these patients in the form of BP monitoring and ABPI, that's ankle brachial pressure index measurements, as well as diagnostics such as renal ultrasound scans and renal blood tests. So what are the risk factors for developing pelvic radiation disease from the vascular viewpoint? And one of the first risk factors are probably underlying cardiovascular risk factors, as evidenced by this study that I quoted, where over 2,000 women underwent radiotherapy for breast cancer, and those with baseline cardiovascular risk factors were twice as likely to have a major cardiovascular event, and those who had a history of coronary artery disease had a 6-fold higher risk. However, as you can see, this is a breast cancer radiotherapy population because the evidence for pelvic radiation is actually quite limited. We also know that the dose of radiotherapy delivered has a linear effect in terms of mean heart dose and the risk of future cardiac events. Again, this is mean heart dose, which is usually not in the field for pelvic radiation, but it's felt that the risk is the same with non-cardiac structures when radiated. So there have been a number of protocols which have adapted the dose reduction, and there have been advances also in planning and delivery techniques, and this has led to better radiation outcomes and better cancer outcomes as well. So how can we decrease this risk? And what the ICOS document really suggests is that any patients who are receiving therapeutic radiation, and this includes radiation to the abdomen and pelvis, we should be undertaking a comprehensive baseline evaluation to screen and optimize treatment of the underlying cardiac risk factors. And before the delivery of radiotherapy, we should be looking at baseline CT chest imaging to see if cardiac calcification is present. So what are the cardiovascular side effects of radiotherapy? And as you can see, the point that I'll highlight here is that unfortunately there is limited data looking at the side effects in a comprehensive way, both at the time and then in terms of late effects as well. So coming now on to the fantastic initiative by the PRDA in producing this toolkit, really just emphasizing, what are the issues here, and I'll go through a number of parts of the toolkit from the vascular viewpoint. So symptoms of pelvic radiation disease: claudication. And this is often described by patients as a pain in the thigh. It can be a pain in the calf or even in the buttocks, and this is on walking or physical activity. They may also talk about pain in the limbs and the swelling of the lower legs. If there are problems with the renal vasculature, which is not uncommon in this context, the patient may not complain of symptoms necessarily, but may have high blood pressure, which can then, of course, lead to symptoms in certain situations and can also have worsening renal function. So how do we assess these patients? And let's see what the toolkit says. So the very important point, as always in medicine, is taking a good history to try and understand the timing of events and also to understand what is happening with the renal function. Patients, as discussed, may complain about claudication pain or leg swelling, and in terms of the renal function, as mentioned, this may be asymptomatic. However, if blood tests are undertaken, they may show deterioration in renal function. Alongside this, if the blood pressure is measured, there may be an unexplained rise in blood pressure or difficult to control blood pressure. Following on from the initial assessment, some of the examination findings would be looking at the pedal pulses, looking for bruits, looking at the ankle brachial pressure index assessment, Doppler flow imaging, and even angiography of the peripheral arteries may be required to make the diagnosis. From the renal side, renal ultrasonography, CT imaging looking for renal artery stenosis may be valuable, and assessing for hypertensive end organ damage is also part of the assessment. What about the management once the diagnosis of pelvic radiation disease from a vascular viewpoint is made? So there are a number of general measures that can be undertaken, and this should really be undertaken for any patient, but for these patients, of course, in particular. Cardiovascular risk factors must be reduced. Obesity reduction, stopping smoking, and increasing physical activity are very beneficial. From the renal side, there may need to be certain dietary changes, and a drug review and removal of nephrotoxic drugs is, of course, very useful. Unfortunately, in some patients, this may not be enough and further management is required. There is a number of different therapies that can be on offer in these patients, and some of them include medications such as antiplatelet therapy. Statins can also be used, as well as controlling the blood pressure with antihypertensive medication. Pain relief is often required for those patients with claudication, and if this is insufficient, they may proceed to either angioplasty, which is peripheral artery stenting, or may even proceed to bypass surgery of the arteries in the lower limbs. In terms of the renal dysfunction, antihypertensive medication is required, and some of these can be renoprotective depending upon the medication prescribed. One of the important points highlighted by the toolkit is that there is help at hand from specialists. So if this is suspected, cardiology or cardio-oncology are the groups of specialists who should be involved in the patient. They can help make the diagnosis and also involve other appropriate specialists if required, such as vascular surgeons. For renal dysfunction, the role of the cardio-oncologist is to help identify this and initiate the treatment, and if there is a worsening of the situation, other associated specialists such as a nephrologist may be required. The PRDA toolkit is also excellent in that it sets out standards and educational resources. The International Cardio-Oncology Guideline on Radiation-Induced Cardiac Issues that I previously mentioned does mention different standards that should be applied both in screening of the patients and looking for acute and late effects, and this gives us all a guideline to estimate our services against and perform local audits. Alongside this, the International Cardio-Oncology Society produces a number of webinars looking at radiation-induced cardiotoxicity, and it's interesting to note that the specialty training curriculum for clinical oncology talks specifically about acute and late-term effects of radiotherapy and how practitioners should be aware of these and be able to manage them. So, what are the key points from the PRDA toolkit? Risk mitigation at the point of delivery of radiotherapy in reducing cardiovascular risk is extremely important and can help mitigate the cardiovascular issues going forward. We know that certain risk factors are present that elevate the likelihood of developing cardiac issues such as older age and traditional cardiac risk factors, and identifying these and appropriately managing them and decreasing the risk factor levels can help manage the risk going forwards. The identification of symptoms after radiotherapy is extremely important, as is referring to appropriate allied specialties such as cardio-oncology early so that intervention can take place as soon as possible. And once identified, the management of this is as per expected for peripheral vascular disease and for renovascular disease. Thank you very much for listening. I do hope you find the rest of the toolkit launch very informative.